look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
Thank you, everyone. It's a pleasure to be here today to share with you all my experience of adopting a What Matters approach into everyday clinical practice. My name's Yvonne Millerick and I'm a nurse consultant for heart failure and palliative care in Glasgow, back in Scotland. So it is a privilege to come here today and spend some time with you. I'm not an expert in cardiomyopathy. You are the experts here in the room, and we hope to be able to learn a great deal from you. My background is very much related to heart failure, which may develop as a consequence of cardiomyopathy. Nonetheless, using a What Matters approach is applicable to each and every one of us throughout your unique experience of living with cardiomyopathy and coexisting disease. So my presentation provides an overview of cardiomyopathy, a brief summary of the best practice guidance, and using a What Matters person-centred communication plan to encourage a bi-directional dialogue and partnership approach between you and your clinical team to inform shared decision-making from diagnosis through to end of life. So as you read this quotation, I suspect that each of you will be able to reflect on a time or situation following your diagnosis that you wished you had asked more questions about the information that your clinical team had provided. Communication affects every aspect of our being, and being able to convey what you need to know with clarity and impact provides you with the best opportunity to understand and achieve whatever realistic goals you may have throughout your care experience. Using a What Matters, Why It Matters, Who Matters, and When It Matters approach can be both empowering and transformational, not only for recipients of care, but also for the professionals who are providing that care. So our starting point must always begin with having a good understanding of your condition. It never fails to amaze me when I see patients at my clinic or during home visits that actually their understanding of their heart failure condition or cardiomyopathy condition is not where it should be. Now, if your understanding from the onset is not where it should be, then it makes things very difficult from there on. Many of you will already know that cardiomyopathy refers to problems with your heart muscle that can make it harder for your heart to pump blood effectively around the body. There are many different types and causes, and it affects people all differently at different ages. Depending on the type of cardiomyopathy that you have, your heart muscle may become thicker, stiffer, or larger than normal. And for some people, this can weaken your heart and cause symptoms associated with irregular heartbeats, heart failure, or more life-threatening conditions. Cardiomyopathy can be caused by your gene, other medical conditions, or extreme stress, and it can also develop or get worse as a consequence of pregnancy. For others, however, the cause of cardiomyopathy remains unknown. So making the connection with your confirmed diagnosis, your symptoms, and your treatment plan is absolutely fundamental to keeping well throughout an illness trajectory. So some people with cardiomyopathy will live with no symptoms and will not need any treatment. Others may develop symptoms associated with shortness of breath, tiredness, and fatigue. Both of them are very different. Dizziness, fainting, and/or chest pain as the disease advances. For others, symptoms may include paroxysmal nocturnal dyspnea, escalation of peripheral edema beyond the lower limbs, which impacts significantly on your day-to-day activities. So it is vital that evidence-based recommendations underpin the management of your cardiomyopathy and should be tailored to suit the specific type and your individual experience of living with the condition on a day-to-day basis. Although there is still a great deal to be done, efforts are being made across the globe to inform what best practice should look like. One example of this includes the European Society of Cardiology, who recently published a large number, 27 to be exact, of key practice recommendations to guide clinical practice from diagnosis onwards. This guidance offers a streamlined approach to accurate diagnosis, specific types of cardiomyopathy, and evidence-based treatments, monitoring and screening throughout the illness trajectory. And although the scope of my presentation today is not to cover these recommendations, it is important that raising awareness and aligning clinical practice does promote a living well with advancing illness philosophy. So what do we mean by living well with cardiomyopathy? Well, this can only be achieved with a coordinated, systematic and individualised pathway that delivers optimised care by a multidisciplinary expert team. Expert review must be timely, responsive and seamless from diagnosis onwards through to end-of-life care as appropriate. Early recognition can be detected pre-birth or triggered in primary care by presenting symptoms of dyspnea, chest pain, palpitation, etc., or during incidental findings associated with abnormal tests. Primary care vigilance is essential to the initial workup to inform cardiomyopathy diagnosis, the specific type, the causes and best practice recommendations. Treatment and management of underlying and coexisting conditions is also essential to ensure that persons can live as well as possible with cardiomyopathy and adjunct conditions. But how can we balance a person-centred agenda alongside a medicalised agenda? Well, evidence tells us that this can prove to be very challenging, particularly as competing priorities, finite resources and time constraints are all too evident in our NHS systems. This can often mean the medical agenda takes priority over a person-centred approach. Blending both agendas is entirely feasible if we are able to adopt a what matters to me and a what is the matter with me approach from diagnosis onwards. So asking what matters to you invites persons to disclose their interests, values and preferences as real people and not just as recipients of care. Physical, mental and general well-being changes are already happening to you and providing you with the opportunity to share what matters, who matters, why it matters and when it matters will enable you to be an active partner in the decision-making process now and in preparation of future change should you become less well and less able in the future. So the End-of-Life Think Tank was an independent group of charities, research organisations and health and social care bodies who came together to develop a What Matters, When Matters programme to encourage lifelong conversations about what matters to me now and for the future. The What Matters approach allows space for reflection, and formulation of questions that matter to the individual and to their set of circumstances. It embraces a person-centred approach which values diversity of cultural and spiritual beliefs and supports how questions, concerns and uncertainty may develop. It encourages a conversational approach rather than a tick box exercise, and eradicates the need for us as professionals to find the right time to initiate these conversations. What matters conversations should be naturally occurring in everyday clinical practice. They can occur at any point following the diagnosis and throughout the illness trajectory. So this particular What Matters Meaningful Conversation Plan enables a process of naturally occurring conversations that allows us to learn more about you and what matters to you. It encourages you to share key aspects of living with your illness. It highlights who is important to you during periods of wellness and periods of change. It provides an opportunity to appraise your expectations of the professional team looking after you. It facilitates conversations about getting to know about your condition and treatment plan. What do you understand about your treatment plan? Is there anything about your plan that you would like to know more about, either for now or in the future? And is there anything about living with your condition now or in the future that worries you? Learning more about your condition and how it affects you on a day-to-day basis is really helpful. We encourage you to describe how you feel most days. If you feel well most days, then that is great. But if your answer to that question is no, is there anything about this that worries you? And is it something that you would like to discuss in more detail? Does your condition and associated symptoms impact on your ability to undertake your usual daily activities? If yes, is there anything specific about this that you would like to discuss in more detail? We also encourage you to think about, if you think about how you are today compared to how you were 6 to 12 months ago, is there a change? Is there a difference? That difference may be associated with improvement, stability, but for some of you it may be associated with some level of change that maybe suggests that deterioration is something that you're experiencing on a day-to-day basis. And if that is something that you're experiencing, is it something you would like to discuss more about now? And also, should that change continue to keep happening over the future? So a key aim of a What Matters approach is to ensure that you are able to live as well as you possibly can, regardless of your stage of illness. We aim to do this by minimising symptoms, stopping the progression of your condition, and reducing the risk of complications associated with any potential adverse events. Appraising both you and your family's understanding of the condition is paramount throughout the illness trajectory. To establish a connection between your condition, the development of symptoms, and evidence-based treatments that permit you to respond to changes in a responsive manner. This is the first step to creating a partnership between real patients and your clinical team. So adopting a person-centred What Matters approach to daily medication requirement is also essential to ensure understanding, expectations and adherence strategies are fully explored, consented to and tailored to suit your individual needs. Not all medications will agree with you or be appropriate for you, but it's really important that we are able to initiate and titrate evidence-based treatments safely and within your expectations. We also want to be able to discuss adopting a flexible medication regime that absolutely enables you to live as well as you possibly can without interruption of frequency of micturition because of the diuretic therapies that you may or may not be taking. Multiple medications is a feature of advancing disease, which will require frequent adjustment, rationalisation in response to improvement and/or deterioration. That is something that will become part and parcel of living with advancing conditions. So lifestyle and daily activity strategies may be required to optimise living well with your condition. And these may include general advice about diet, sustaining from alcohol, and weight management, which all contribute to positive well-being for living with your cardiomyopathy and comorbidities. These strategies begin at diagnosis, but they continue throughout an advancing trajectory and will be adapted to suit as appropriate. They will be aligned with individuals presenting symptoms and ongoing concerns. Patients with advancing illness may require psychological support or referral to other specialist teams, and that is really important in order to provide and introduce the unique contribution of expert skill sets in order to optimise your care and support. And this may include specialist advice about the comorbidities that often partner cardiac disease, such as respiratory, diabetes, atrial fibrillation, and so on. So regular low to moderate intensity exercise is recommended in all able individuals with cardiomyopathy. An individual risk assessment for exercise prescription is recommended in all patients with cardiomyopathy. Regular exercise confers to an overall cardiovascular, psychological, and quality of life benefits. And additional information related to specific cardiomyopathy phenotypes and exercise should be discussed with your clinical team. So it can be helpful to think about forward care planning as 3 distinct phases to guide integration of supportive, palliative and end-of-life care principles underpinned by meaningful conversations associated with living well, preparing for progressive change if reversible causes for deterioration cannot be found, and end-of-life care with a real focus on being able to live as well as you possibly can throughout. It's about early identification, exploring what matters, sharing what we can do, explaining what will not help, and planning the care together. So advanced therapies may also feature for some people with specific symptoms and types of cardiomyopathy. And this may include an implantable cardiac device to minimise risk of life-threatening arrhythmias. A long-term or short-term LVAD, which helps the heart to pump blood to the body, is sometimes used as a bridge to transplantation. And transplants are performed in people who are experiencing significant symptom burden associated with advancing heart failure, often referred to as end-stage heart failure. We must always be mindful that living well alongside advancing disease and waiting on transplantation will also require specialist input from our palliative care teams. And we should always be thinking about advancing disease, living well, and palliation running parallel to one another in order to optimise the care and support for patients and families. But without a doubt, communication underpins all aspects of a cardiac palliative care approach. A paper by Professor Fitzsimmons highlighted that poor communication was ranked number 1 out of 3 themes which contributed to suboptimal care experience. Barriers cited for this suggest that advancing illness was perceived to be associated with difficult conversations, uncertainty, and a lack of confidence by professionals as to when was the right time to have these conversations. I maintain that if we perceive something to be difficult, then we will continue to avoid having them. So unless we begin to perceive that these conversations should be regarded as key requisites for living well in response to inevitable change, then advancing illness and living well may not be realistic. So in the absence of clear communication and future care planning, care is often subjected to a system that focuses on a reactive model of care, where the patient experiences a crisis episode, which often results in admission. If, however, we are able to adjust a reactive model to a proactive model, then we can minimise any poor experience for patients and families. The seamless integration of core components of care helps to manage professional, patient, and family expectations throughout. Early identification of prioritising of high-risk patients to one of 3 groups, a comprehensive assessment to determine the cardiological and comorbidity and person-centred needs, and adopting a what matters approach to future care planning discussions. But equally important is cohesive working with the multidisciplinary team to ensure that we are able to facilitate high-quality care experience. Evidence highlights that in the absence of early identification and meaningful person-centred conversations, patients and families continue to experience suboptimal clinical outcomes with frequent reviews by the clinical team or admissions to hospital. So how can we identify high-risk patients? Well, we want to be able to identify those that are experiencing significant symptom burden. These may be patients who are vulnerable to hospital admission or frequent review by their care team. They may have coexisting disease that is significantly impacting on their cardiac care, and they may be experiencing change associated with their ability to do day-to-day activities. Studies have highlighted that patients and families living with advancing illness not only hope to experience a level of wellness and stability, but also want to be informed about treatment options, including a strong preference for information to be disclosed about the possibilities of deterioration associated with advancing disease. But how conversation ready are we all here in this room today? We plan and prepare for so much change in our life, marriage, birth, and moving house. And yet we very rarely invest the same amount of time to thinking ahead and making plans for the physical, mental, and general well-being changes that will happen to each and every one of us. Please remember that talking about inevitable change now does not mean it will happen anytime sooner. And furthermore, an uncertain illness trajectory with irreversible factors should only reinforce the importance of engaging in meaningful conversations now and for the future. So we should consider future care planning as a support to help people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. Future care planning uses person-centred communication principles and behaviours associated with connection, assessing, responding, and empowering to enhance the professional, patient, and family relationship. Shared decision-making is a prerequisite of person-centred care, informed consent, and realistic medicine. And these are 2 examples of communication tools that you may see used in clinical practice. So the communication plan that I referred to earlier has been developed by professionals and people living with advancing illness. It has been designed specifically to encourage communication with a real focus on enabling people to live as well as possible. It is important to remember that everyone's experience will be different. Some of the questions contained within the plan will have more meaning now to others, and for other people, all of the questions may have some relevance depending on their individual experience. The communication plan is designed to encourage two-way dialogue between the professional, patient and caregivers. The questions help people to think about what information is helpful now and what information would be helpful for the future. It can also be used as a probe to provide additional information or to enhance understanding, manage expectations and inform decision-making, and help professionals to plan your care in partnership with yourself and your family. So we have already spoken about future care planning conversations that promote good care for persons whose health and well-being is changing with advancing illness. Generally, there is a degree of uncertainty when having these conversations, as no one can predict what happens in the future. However, care planning involves discussion with the right people. It is about finding out what matters, when it matters, and talking about what we can do, and explaining what will not help. Planning your care together promotes an approach in preparation of inevitable change happening at some point in the future. So from a patient, carer and professional perspective, future care planning provides an opportunity to provide an approach that aligns with the modern healthcare system by promoting maximum shared knowledge, understanding and minimal uncertainty throughout. But one of the greatest moments in life may be when you find the courage to let go of what you can't change and focus more on what you absolutely can. By doing so, your experience of living well with advancing illness will enable you and your loved ones to experience true person-centred care and support at the right time, in the right place, and at a time of real need. And from a patient, family and professional perspective, there is simply nothing more rewarding. Thank you.
Thank you very much. So, a little bit of a change now. So what we're going to do, I'm going to sit down with Yvonne and just ask her a few questions about the document. But before we do that, I just want to read the room a little bit. I want to see, was anybody aware of the document before today? No? Yourself? You. So I know we've got some clinicians here and healthcare professionals. So were you aware of the document before today? No? No. Okay. So that's great. So we're going to sit down and I'm just going to ask Yvonne a few questions, if that's okay. And after that, I'm going to do a 5-minute presentation and then we'll have lunch, if that's okay with everybody. Thank you very much. It was great. Okay. Sit down. So first of all, then, I'm just going to ask, what made you and the working group develop this document? So for you that have not aware, we've got the document here, but also we've got copies at the back, so please feel free to pick one up before you go. So yeah, so why did you feel it was important? What made you and the working group develop it?
The working group consists of myself, Caryl Barton, who's a nurse consultant from London, and Jenny Wellstand, who's also a nurse consultant from Wales. And collectively, we have been making changes throughout the heart failure disease trajectory. But the evidence all pointed to the fact that persons living with advancing illness were not receiving the care that they wanted as they were approaching end of life, and that their experience was more related to a reactive model of care. And whilst for the clinical team, it was not a surprise that the person was deteriorating, conversations which were considered to have taken place in clinical practice had actually not been understood the way that they should have been with patients and families. And inevitably what that results in is suboptimal care, unrealistic expectations, and also their families and patients are perfectly within their right to complain. And certainly the complaints across NHS in the UK are mostly related with advancing illness and end-of-life care.
Communication, isn't it?
Yeah.
Key.
So communication, as I've said, underpins every aspect from diagnosis onwards. And what we wanted to develop was a document or a plan or a tool that enabled naturally occurring conversations from diagnosis onwards. Many people at the point of diagnosis will be at their sickest. However, following introduction of evidence-based treatments, they will then become well, stabilise and live a fulfilled life until such times as things change for them. Other people will be well, reasonably well at diagnosis, but then will experience change throughout their illness trajectory. And this document fits at any point in the illness trajectory and enables people to have conversations that are either initiated by patient and families or initiated by professionals at any point.
Yeah, I concur, because apart from my role working with Cardiomyopathy UK, I do work for the NHS. I'm a heart failure specialist nurse in the community, and I can certainly, reiterate everything that you've said, and I think that we do see that in clinical practice, which, is far from ideal care. So that goes on to my second question then, really. So who do you feel should initiate and instigate these questions? Do you think it should come from healthcare professionals? Do you think healthcare professionals should say, this is a document, have a look at it? Or do you think it should be maybe a bit of the patients? And I'm very much an advocate for, patient education and patient support and advocating patients to be an expert patient then, really. So do you think it should be the patient saying, I'd like?
So I think the answer to that is anyone can initiate these conversations. Ideally, it would be great if patients and families felt comfortable enough to initiate the conversations with their clinical team. However, I don't think there's a right or wrong answer to this, and I think that as clinicians we do have a duty of care to ensure that patients and families fully understand how things are just now, what the expectations are from a realistic perspective, and what may or may not happen going forward, so that they are fully prepared at every stage.
Yeah, so it's just, it shouldn't be like a healthcare professional should be educating and trying to empower the patient to get it, but also patients shouldn't be that scared. They should be saying, actually, these are what's important to me, and this is what I want to talk about. Yeah.
I think the important message about the plan is it's not a one-off event. It is an evolving conversation, and what's important to someone perhaps at diagnosis will not carry the same importance if they're experiencing change.
Absolutely, yeah. So have you got any questions for me? Because, like I said, I have used this tool in practice, so
we're currently evaluating the tool across 25 UK heart failure sites, and Caryl has been involved in the evaluation. So it would be interesting to me to learn from your professional experience, how would you describe using the What Matters Meaningful Conversation Plan in practice?
I think the main thing was, when you see the document, it's quite a daunting document, even though that there's 3 sections to it, there's quite a few questions. And I think initially you'd, the patient. And also what's really important to remember is that it's not just for the patient and the individual, it's for the carers, it's for the family, it's for all, using all of that. So I think that's really important to remember. And they might think, oh, it's a lot of information to take in or that, but when they go home and they they really think about it, it just opens up that communication tool, It's so I think it's got really important questions. Like the main question for me was like, who is important to you in your diagnosis? And then it's like, well, actually, when you're feeling unwell, what individual is important to you? And you'd think, maybe I'd had a preconception of like, well, it might be the same individual, but it's not necessarily. So it's just highlighting things like that. It highlighted a lot of things, but in practice, it's that open communication tool. And I really, I want to reiterate, when you think when you're newly diagnosed and you've got that information, it's completely different when you're on that trajectory, because, the fluency of an individual with advanced and chronic condition, what their day-to-day needs are very different. How they might feel today will be very different to what they might feel maybe when you see them tomorrow or the next week, So it takes that into account. It very much takes that into account. And I think that's the most important thing, in practice.
I think one of the other things that the tool offers is evidence of improvement, stability, or change associated with deterioration. And often as clinicians, we don't always get the opportunity to see that. But I think that also applies to patients and families. That it's not until they're maybe invited to think about how they were 6 to 12 months ago and compare how they are now to then that they realise that things are changing for them. And should that change continue over the next 6 to 12 months, what are the key things that are important to them that we as clinicians can help to support them with in preparation of that change continuing?
And I think it just encourages the patient and the family and the carers to share that information that they might not necessarily. It gives them that, okay, well, I'm allowed to do it. It gives them that, okay, this is what, because I think sometimes when I've got clinics and you run clinics, I think you might be a bit like, well, these are the certain questions that I have to ask and we need to know these, but it's putting the ball back in their court of what's important to them, because what I sometimes as a healthcare professional, you don't understand, like patients have been, and I'm sure a lot of you here can reiterate that, like you've been waiting a long time for this appointment, so this is your, like, and it might be like 15 minutes, 20 minutes, and for you, that's, you've, a lot of time to, like, you've thought about it, you've thought about what questions, and when it comes to it, you've got the healthcare professional there just asking you these questions, like, oh, I forgot, so it gives you that tool, it gives you that, absolutely. I think. Any other questions that you've got that you're thinking?
Would you consider using the tool routinely now in clinical practice?
Absolutely, because it's a holistic tool. It just doesn't look at your, your cardiac condition, that it looks at you as a whole, as an individual. So I would definitely be using it. And what surprised me is, because if you've got an expert patient, they might know everything that they know about the condition, or you might get another patient who knows everything about the medications, because that's what's really interesting in them. But you have to go through certain things. But what this tool has showed me is that it focuses on what's actually important to them, and actually I want 10 minutes discussing this at this appointment today. So that's what I think. So you've mentioned that you did the evaluation, and there was 25 centres across the UK that undertook this evaluation. Was there anything that you think that surprised you from the evaluation? Was there any curveballs?
So I can't give too much away because we are hoping to publish the analysis I was overwhelmed by the response rate, which was 91%, which is a huge achievement with this type of activity. Actually, overwhelmingly, patients, families and professionals liked the tool. They were invited to engage in additional changes that they would make to the tool, and we're taking that on board with specific questions. But overall, they seemed quite happy with it. And some of the comments that have come back is that professionals who have been very experienced compared to professionals who are new, there was something of benefit to all of them from using it. And they themselves opened up and said that a lot of the answers that came back from patients and families using the tool, as a professional, they had never discussed or considered that was something that was of real importance to them. So that there's opportunity there from both sides.
Yeah, definitely. And I think it's about not missing anything that's important to the patient, isn't it, and individuals and the families. So, after the PowerPoint presentation and listening, do you think that is something that you would like in your appointments going forward? Do you feel? Do you think it would benefit you? Yeah?
Views about what they want. Oh, thanks. Yeah. Have different views about what they want in future, or even sharing prognosis information with the family. You know, I've certainly been in lots of examples where a patient might say, don't tell my wife, or, you know, I want my ICD turned off, and the rest of the family just want, you know, every possible chance to be given to somebody, even if they don't personally feel that their quality of life is such that they want that to continue anymore.
So there is a section on the back that offers the opportunity for conversations about additional topics, and cardiac devices is one of them, as is cardiopulmonary resuscitation, preferred care wishes. So I think that what it does do is provide an opportunity for open discussion to take place. Clearly, if the patient has full capacity, then we would need to agree that other people could be involved in that conversation. But what, from a clinician perspective, what that might highlight is that there is some
communication concerns
with it, and certainly when someone is experiencing change, and if that change is associated with deterioration, then as a professional team we would want to be able to engage in everyone that's important to that person, including their family, with, you know, in order to facilitate realistic care choices as appropriate. One of the things that strikes me about conversations like that is I keep going back to the understanding. People don't always understand about cardiac devices. They understand that it's the mechanism in which it's keeping them alive. But no amount of cardiac shocks can stop a failing heart. And there comes a time where we have to assess the benefit versus the risks of any treatments, including devices. And it's about engaging in open conversation in a timely manner about what people's fears and concerns are, and allowing them to almost inform the conversation as their understanding develops.
Definitely. I think the tool definitely enables the patient to become an expert patient, you know, and in their own care, and I think that's definitely it. Of course.
The other end of the spectrum, my wife's currently asymptomatic, has been told in the next, she's asymptomatic, but told the next 3 to 5 years she can expect to start experiencing symptoms of heart failure. I wonder if you could talk about the pros and maybe even cons of starting the conversation now before it actually starts.
So that is the aim of the What Matters communication tool. Bearing in mind that it's an evolving conversation and that decisions made now can absolutely change as things progress. So it's really about exploring, you know, with your wife, what is her understanding of things just now? Does she have any concerns about what's happening to her just now? Or does she have concerns that she wishes to discuss for going forward? I think it's something that each and every one of us should be discussing with our families around what might we wish for as it became apparent that things were changing and there was no reversibility from the deterioration that we're experiencing. I think as well, I stay away from timelines. You know, no one can predict how long somebody has, and a timeline of 5 years could be 10 years, it could be less. And that's applicable to each and every one of us here in this room for lots of different reasons. So timelines are not helpful. The here and now is. And I think focusing on conversations about now, but also the what ifs and preparation of deterioration going forward.
Definitely. Okay. And I think with the timelines, that is the first question that an individual diagnosed with cardiomyopathy or any cardiac condition, that's the first thing that they would want to know. There's like, you know, they go on Dr. Google and they say, well, I've got this, that. So I think it's bringing it back, isn't it, and going it, definitely, yeah. But it's a very common question that we have on a daily basis. Yeah.
As a social worker, I was quite impressed by this. As a social worker, I was quite impressed with this person-centered model because a lot of social workers move away from practitioner skills to care management. Yeah. So I suppose there's two questions. I suppose one, are social workers involved with this as a multidisciplinary team? And secondly, has this been used for other models of care other than heart disease or other symptoms? Yeah.
So the What Matters is a national strategy, and it's been used in hospital wards. You know, the What Matters to me, and you see the posts up behind the bed. So to me, you know, that is one example of it. Our team have taken it a different way and identified that actually integrating the principles of a What Matters approach into a chronic illness is something that can work really well. And certainly what we found was that the learning from the What Matters is transferable to any illness.
I've worked in mental health, that seemed to be a very good model for what does happen and what ought to happen. So thank you.
Yeah. Okay. So can I just how much time have we got left? Just to 5-10 minutes. Okay. So what I'll do, maybe I've got a presentation now just regard to what the charity can offer with regards to advanced care and advanced care planning, and then we'll have 2 or 3 minutes for any questions, but I know I'll be by the stand over there, so if you've got any questions, please come over and ask, or you can have the email address and you can always email.
We've also got some on the app as well already.
Okay, well I'll do this and then we go back to the app. Thank you. Yeah, so from my stance then, now I'm going to talk about what the charity can offer. So I think it's really important. We are at Cardiomyopathy UK Conference, National Conference. It's really important to reiterate what our values are. So I've got that It's about caring and being collaborative and being realistic, and I think that comes back to the talk that we've just gone through, hasn't it? But so we've got a variety of support groups. We've got both face-to-face and we've got online. And I know that Louise is here. You've run a support group, or you've got a support group in Swansea, and that's very much a face-to-face. After COVID, everything went, everything was online. But now, fortunate enough that we're going the hybrid approach and online, and we've got online resources, and we have got one-to-one peer support. With regards to the online resources, I printed some information off, but they're all on our webpage, and Christy, he's the person to speak to regarding one-to-one peer support, and the feedback from peer support is really, amazing, the feedback that we've had. So I would encourage anybody who's thinking about that to go through and do that. Hands up. Has anybody in the room had the one-to-one peer support? I know we've got some individuals that actually carry out being the peer and the individual, but anybody undertaken it? No? It's something that to look into. I would definitely recommend that. And I think the support group that I'm really heavily involved with is the Advanced Heart Failure Towards Transplant online support group. We've got a few members here. So hands up then, is anybody in the realms of being referred for a transplant or had a transplant, apart from you? Yeah. So this definitely is something that we can offer and we can support, and come and have a chat. There's loads of the members here, so I'm so glad so many people made it down to London. It was amazing. So we've got that support group, so please, and then let us know. And we've got specific ones, so we've got coping with breathlessness, we've got about heart failure, so that's in the back. Please feel free to pick up a copy and take it home. Bedtime reading, or you can read it on the journey home, either or. And then, like I said, the peer support. So that's just a whistle-stop tour of what we can offer, because I think it's really important that everybody in the room knows, yes, we've got an amazing conference and it happens every year, and all of these information will be on YouTube, but the charity have, got so much up-to-date information as well, and that's really important. Like, the web page is updated regularly, and we've got really up-to-date information. And these are some recommended readings. So shall we go and have some questions then now? Just to wrap it up, and everybody can have a nice lunch.
Here we go.
Okay. Okay. Do you want to read them out? Then, yeah, and then I'm just thinking, yeah.
No worries.
I'm just thinking.
Okay. So this is one of the ones that's come through on the app. Are there tests which can predict the risk of getting worse, heart failure, and or sudden death in people with cardiomyopathy?
So the main thing, I'll answer and then you can add on. Yeah. I'm just thinking the main blood test, if you're talking about that, is a blood test called NT-proBNP. And that can just, it's like, do you want to explain the test a bit more, NT-proBNP?
So it's a protein that's broken down, and we do a blood test to determine the levels of that protein, and if it's greater than 400.
So we have a baseline. And then it's the symptoms, isn't it?
So people with significant symptoms, their NT-proBNP will be greater than 2,000.
Yeah. But not necessarily. With regards to advancing care and heart failure, then really it's regarding the symptoms that you experience. It's the breathlessness, it's the gaining weight, it's the fatigue. But with regards to the test per se, it would be the NT-proBNP, and actually it's just the echoes, echoes and MRIs. And
I think doing the NT-proBNP in isolation is not enough to inform that things are advancing. Yeah. It's more
holistic.
It's the holistic, if they are experiencing resistant symptoms.
Yeah. Have we got any questions in the room?
He was diagnosed with heart failure, and before COVID, and then it took all the way through till just this year to find out what kind of heart failure it is. So I was just wondering, could the doctors and the people who see you actually explain that better when we actually get that information?
Okay, so
that really spent 2 years of worrying when a simple explanation solved it.
yeah, and that relates right back to how I started my talk, in that if we were able to empower yourself to think about what does it mean, this diagnosis, what does it mean, and how will it impact on my day-to-day living. And it you know, I've been in nursing, dare I say, nearly 40 years, and I've spent 25 years in heart failure. And even now, you know, patients come with the diagnosis, they've lived with it for many years, but actually they don't have a good understanding of that. And the etiology of heart failure is really important because it informs the treatment plan.
Okay. I'm sorry that you've had to go through that, because it sounds like you've had a tough few years, doesn't it? Yeah.
Just not knowing that.
Yeah. And again, it's that open communication, and maybe, you know, 10 minutes, 15 minutes consultation would have, you know, pointed you in the right direction and given you information that you need and require, isn't it? Yeah.
Thank you. I'll take another one from the app. So what happens to people with cardiomyopathy as they get older? How does the condition change over time?
I think, shall I answer that then? I think with cardiomyopathy, I think it absolutely depends which cardiomyopathy you're diagnosed with. And again, it's down to the pumping function of the heart. So it's regular tests and regular, you know, investigation. So your echo, your MRI, and that will show the trajectory. Some individuals might be diagnosed with cardiomyopathy and live very much symptom-free. But I think the essence of that question, again, goes down to how symptomatic you are, to how well your heart is actually pumping and functioning with the diagnosis of cardiomyopathy.
We've got time for another one in the room before we've got lunch. Anybody else?
Just actually a quick observation, probably a little lighter than families particularly. Conversations come up at the oddest of times you've kind of got to be ready for. I mean, this is where I have this attitude of my ideal ending is going to be certain and doing something really inappropriate at the time. But I was a Ramstein gig last year, and suddenly in the queue for the gig, my daughter said to me, "If you keel over, what do you want doing?" And we had the whole DNR or not conversation in a queue for, and that was a really good conversation, but you have to kind of, relatives are a funny thing.
Yeah. So that fits in with the elephant in the room. You know, it's a conversation that's bubbling under the surface for all of us, but actually when is the right time to have it? And grasp the opportunity. As a clinician, I'm prepared to engage in that conversation at any point with patients and families that are coming in to see me. It's not right that we define when those conversations happen. It could happen at any point. And it's about you could change your mind. There's nothing set in stone. But actually, I think all of us here in this room have a vision of how we would like things to be at the end of our life. And therefore, it's really important that with families that they understand why we might think that way and why that's important to us. But equally important to healthcare professionals, because they will ultimately be responsible for facilitating your care preferences.
Thank you.
So I was going to say, so just to close up, I think the thing I want to say mostly is when you've got a diagnosis of chronic condition, there's a lot of things that are out of your control and a lot of things that you can't control. and it's very difficult. And I think this document, or having these open communications, brings that control back into it. And I think that's good.
The focus of this document is not on end of life.
No.
The focus of this document is about living as well as you possibly can throughout an uncertain illness trajectory. And that is the difficulty sometimes, is that people perceive it to be associated with someone who's imminently dying. That is not the purpose of this. It's very much about evolving conversations in response to change, and that change may be associated with improvement, stability, or deterioration. Okay.
Can I just ask, so you said that it's a trial currently and evaluation. So longer term, what's your expectation in terms of when and how patients would access that document? Is the kind of thinking that as soon as you're diagnosed with cardiomyopathy, you will be made aware of this document at the start of your journey, or where does it fit in?
So I think that would be the expectation. The next part of the evaluation that we're doing is in partnership with the Scottish Government. But there is work that I've been involved with Jenny Wellstan. She led a piece of work for NHS England, and it was around the 6 ambitions associated with advancing illness and supportive palliative and end-of-life care. And certainly the What Matters approach features heavily in the NHS document, and we perceive that the Scottish Government will follow a similar line. So it doesn't need to be this one. It can be your own version of a What Matters document. The key to this is about starting the conversation, informing your care, feeling empowered and enabled to make decisions along the way. Could I just...
It's a really interesting one, because it's that kind of balance of, okay, you've got cardiomyopathy, but kind of you're okay, and you could carry on for the rest of your life and be absolutely fine, as opposed to, well, we need to, or you might start having these conversations and thinking about, does that set in a kind of level of fear?
So this is your document. You define the questions that you want to answer and the ones that you don't. Where there might be concern is if somebody who was sitting in front of me was clearly deteriorating and these conversations hadn't taken place. As a clinician, I would maybe want to initiate a conversation that at least allowed me to establish that the patient did realise that things were not going as well as we would hope, and give them the opportunity to inform, what or not what they would like to happen going forward. Okay. Could I just ask one question? Is anybody upset by the document being discussed today?
There's a thumbs up there.
Okay, thank you, Yvonne.
Just make one comment.
My father was diagnosed with Alzheimer's, and as the eldest child, I was the one that took the lead on my parents' care. Dad had been my mother's primary carer. And I found a document very similar in Dorset. And I have to say, I went through that with both Mum and Dad at the same time together. The whole family were involved. They heard what Mum and Dad wanted. And it made life so much easier for all of us when they weren't able to say what they wanted. And it helped us do what they wanted to happen as far as we could. There were obviously things that were taken out of our hands, but we were able to take the steps that we wanted to take in the way that they wanted the end of their lives to be like. And it took a big, big weight off of our shoulders. So I would encourage anybody who is in any similar situation, no matter what the illness, even before there's any illness diagnosed even, just to talk about things and let everybody know. It takes a hell of a weight off your shoulders.